Respected chairpersons, learned delegates, learned faculties, it's indeed a great pleasure and an honor for me to be delivering this talk in front of this August gathering. I thank the Endocrine Society of India, the organizers of We Care, and the Maharashtra Endocrine Society for inviting me. So coming to the topic, the clinical assessment of a person with obesity. So the purpose is to establish the diagnosis, identify the triggers and causes, and identify obesity-related comorbidities so that obesity can be staged according to the severity so that we can set the targets as mentioned by Professor Shashank Joshi and discuss the management options. So the clinic should be a multidisciplinary team where the healthcare professional should be well-informed, trained, empathetic, sensitive, and non-judgmental. The spaces available should be wide and areas for easy movement, private room for weigh-ins. Broad and armless chair equipment should be appropriate, and the reading and information material available should be educational and non-biased. So I'm presenting two case scenarios which are hypothetical but which are typical of the patients we see. So one is a 41-year-old lady who complains of excessive weight gain since the past 6 to 7 years. She says that the problem started around 10 years back when she was diagnosed with primary hypothyroidism. Since then, she has made many futile attempts to lose weight, and she feels tired most of the day and depressed about her weight. And she thinks the problem is her thyroid and thinks that it's a high time she consulted her endocrinologist. Another one is a 23-year-old lady who has irregular cycles in the form of oligomenorrhea. She has irregular meal timings and no exercise because of the demands of college work. She thinks she has PCOS, otherwise she feels fit and active, and now she plans to consult a gynecologist, a physician, or an endocrinologist. So the presentations I'm projecting today are from the guidelines of the Endocrine Society of India and the Canadian Obesity Network. So the Canadian Obesity Network talks about the 5 A's of obesity management. The first A is ask permission. So we need to ask the patient whether it is all right to talk about her weight. So the second patient did not think that the weight was a problem. She thought the PCOS was a problem, but we understand that the PCOS was actually related to the weight. And even the first lady who thought, for her, where the weight was a problem, we still need to take permission from her to ask her the details about her weight and about her weight history. And this will help us assess the patient's story and also help classify obesity according to the BMI categories, and more importantly, the severity of disease based on the presence of complications. And further, that will guide us on advising on the management, agree on goals, and assist with drivers and barriers. So like any medical examination, the clinical examination will be a detailed and focused history and comprehensive examination. So we will ask for the weight history of the patient, how long she or he has been suffering, what was that specific life event that precipitated it. It could have been a board exam, a competitive exam. It could have been a demise of a spouse or a parent, or it could be just after delivery. Also, the nutritional intake of the patient needs to be analyzed, and the nutritional literacy of the patient. The physical activity, about the duration of the sedentary time, and also about the presence or the absence of physical activity. And if there is no physical activity, to ask why is it so, whether it is because of the lack of time, the lack of energy, or the lack of motivation. Mental health assessment is extremely important. Addiction and dependency, including dependency on, let's say, sugar, sweetened beverages, any physical or psychological abuse the patient has undergone, and medications, sleep history, family history, social history are all important. The obesity-centered physical examination should have at least 2 anthropometric measures, that is the body mass index and the waist circumference, but we would examine the patient for all the important organ systems from head to toe, because obesity can be associated with so many complications of different organ systems, and identifying this will help us identify the severity of the involvement and thereby identify the stage of the disease which the patient will be on. So when we diagnose obesity, Yes, the BMI and the waist circumference will give the anthropometric measures, but what is important is the staging of obesity, and here I have referred to the Edmonton obesity staging system, which were the pioneers in this line of thought. So if we classify obesity, the BMI more than equal to 25 kgs per meter square is obese, grade 1, and then we have the different grades like grade 1, grade 2, grade 3. But what is important is that this classification is different from the Western counterparts, where for the Caucasians, the cutoff for obesity is a BMI of more than 30. This is because we have a higher body fat percentage compared to a Caucasian. So we know about the Lancet paper, about the famous YY paradox, where despite the fact that these two physicians, Dr. Yagnik and Dr. Yudnik, had the same BMI, Dr. Yagnik, who is an Indian, had a percentage body fat which was 2.5 times that of Dr. Yudnik. And therefore, the obesity indicators in India are a BMI of more than equal to 25 kgs per meter square, the waist circumference of more than 90 centimeter in men and more than 80 centimeter in women, and if DEXA is available, then we may go in for a percentage body fat determination. But what is important is the assessing of the obesity stage, and here I take the privilege of discussing this topic, which has been put forward by Dr. Arya Sharma, who is the next speaker, in the International Journal of Obesity way back in 2009, where they said that it was not sufficient to just look at the BMI. We need to look beyond the BMI to look at the complications of obesity, so that obesity staging can take place as we do with so many chronic diseases. And the 4 M's framework of the obesity assessment are the mental health, the mechanical, the metabolic, and the social milieu. So the Edmonton obesity staging system takes into account, complements the BMI, and takes into account the presence or the absence of complications, and if the complications are present, what is the extent or the degree of the complications. So it has 5 stages. Stage 0, no complications, whereas stage 4 could be end organ involvement. So to take an example, stage 0, patient may have an obese related BMI, but still there is no other complications, and whereas stage 1 is preclinical, so obese by the BMI criteria, but has borderline hypertension, impaired fasting glucose, mild physical symptom impairment, etc. And in stage 2, there is comorbidity. So patient could be having type 2 diabetes, could be having hypertension, or like the second girl, she could be having a polycystic ovary syndrome. In stage 3, it is more advanced degrees of the end organ involvement in the form of acute myocardial infarction or diabetes complications. And in stage 4, there is end organ involvement, for example, end stage kidney disease, end stage liver disease, which could be cirrhosis or even hepatocellular carcinoma, and severe disabling osteoarthritis. And the Edmonton obesity staging system independently predicted increased mortality even after adjustments for contemporary methods of classifying adiposity. And in fact, the utility of the Edmonton obesity staging system for the prediction of COVID-19 outcomes was also seen in this multicentric study, which was recently published in the International Journal of Obesity, where it was found that patients with overweight and obesity, but who were in the stage 0 and 1, had lower risk of mortality than patients with normal weight, and therefore BMI does not adequately reflect the adipose tissue associated disease. And the EOSS categories could be present, stage could be present across any BMI categories. So somebody would be having a class 1 obesity, but at the same time could be suffering from a stage 3 severity of the disease. Or somebody could be having a class 3 obesity, that means higher BMI, but could still be suffering from, let's say, may still not have any of the complications of obesity or mild complications, and thereby staying in stage 0 and stage 1. This slide also has been discussed by Dr. Shashank Joshi, where the staging of obesity actually, and thereby the identification of the complications, actually guides us to the extent of weight loss we may afford. So for the prevention of type 2 diabetes, maybe 5 to 10% weight loss. But for the remission of type 2 diabetes, or for, let's say, for the regression of fibrosis in NFLD, it could be as high as 15, even 50%. So Having said this, when to suspect secondary causes of obesity, when there is a positive history of offending drugs like glucocorticoids, antipsychotics, anticonvulsants, hard signs of Cushing's, history of or features of hypopituitarism, features of significant androgen deficiency in men and androgen excess in females. So while some degree of androgen excess in the form of hirsutism, in the form of acne, oligomenorrhea may be seen in women with obesity, and some form of hypogonadism may be seen in men with obesity, but severe forms of virilization suggest a secondary cause of obesity in females like an androgen secreting tumor or a Cushing syndrome, whereas in men the severe degrees of undervirilization could suggest that the hypogonadism is the primary cause of obesity. Then the features of syndromic obesity like hyperphagia, dysmorphic faces and limbs, and developmental delay, or very young onset and family history of very young onset obesity. So coming back to our first patient, she has a BMI of 33, so her obesity class 2. But she has osteoarthritis, she has hypertension, and her depression, her psychopathology is significant depression, and therefore she classifies for the severity or the EOSS stage 3. Coming back to our second patient, the BMI is 29, so she is obesity class 1. But she has got a disease in the form of polycystic ovary syndrome, so there is manifest disease, therefore she is EOSS stage 2. So the take-home messages are, the clinical assessment helps diagnose and identify causes. BMI and waist circumferences need to be complemented by obesity staging. Staging informs how sick an individual is rather than how heavy. And staging helps determine our treatment goals. Healthcare providers should be well informed, have empathy and sensitivity, and hospital and clinic setup should be conducive to the patient needs. Yet there are many questions that remain to be answered, so we are taking our baby steps in our understanding of obesity. Something as simple as a nomenclature of obesity also needs refinement. For example, what do we call something that is not secondary obesity? So do we just term it as obesity it's only, or should we call it simple obesity? But definitely it is not simple obesity as we know. The term we have been using is exogenous obesity, but then we understand that this current pandemic of obesity, even if it is exogenic, there is exogenous, there is actually an interaction which is maladaptive interaction between the endogenous factors, and therefore even the term exogenous obesity needs to be modified. So I think many changes would take place in the nomenclature, in the classification, like it has taken place in diabetes over the past decades and is still continuing. Thank you.